Good afternoon. My name is Nathan Ray, and I'm the director for the Arkansas Regional Extension Center for Health Information Technology, HITArkansas. HITArkansas is a division of Arkansas Foundation for Medical Care, the state's federally designated quality improvement organization. Today, I am pleased to facilitate a roundtable discussion among several key stakeholders that help lead healthcare-related initiatives throughout the great state of Arkansas. We will cover topics including electronic health record adoption, patient engagement, and other health improvement initiatives. I would like to begin this discussion by going around the table and having each of our stakeholders introduce themselves and the roles and responsibilities with each of their respective organizations. I would like to start with Jonathan Fuchs, the COO of AFMC.
Hi, I'm Jonathan Fuchs. I am the Chief Operating Officer for the Arkansas Foundation for Medical Care. I have the executive responsibility for HITArkansas, as well as a number of our provider outreach and operational activities, including information systems and communications and our quality improvement organization.
Thank you, Jonathan. Dr. Kahn?
My name is Arlo Kahn. I'm a family physician. I'm on the faculty at UAMS, and I am a policy advisor at the Arkansas Center for Health Improvement.
Thank you. Mr. Morin?
Edward Morin with the Arkansas Department of Human Services in the Medicaid division. I'm a program specialist. My main and only focus is the electronic health record provider incentive program.
Thank you. And Mr. Scott?
I'm Ray Scott. I'm the State Coordinator for Health Information Technology and direct the State Office of Health Information Technology. And our primary responsibility is to try to build a statewide infrastructure, statewide network to connect a variety of healthcare organizations to one another to enable them to be able to move electronic clinical records between those points of care in order to better inform care and improve patient healthcare outcomes.
Thank you, Mr. Scott, and thank you to all of our stakeholders for taking the time today to discuss how we can work together and collaborate among the many initiatives we're working on in the great state of Arkansas. Now, I would like to start with Dr. Kahn to speak to some of the initiatives and policies that ACI is overseeing with regard to healthcare improvement in the state.
Well, Arkansas Center for Health Improvement, which is also called ACI, is a health policy institute that seeks to develop policy to improve the health of Arkansans. So our main foci over the years have been in four. The disease prevention, health promotion is one. Healthcare finance is another. Access to quality healthcare is a third. And the fourth is the data analysis, health data analysis. With regard to healthcare reform, Arkansas Center for Health Improvement has been involved in four main areas. We realized years ago that the patient-centered medical home was going to be the model, and we developed a vision for what that model would entail. With regard to today's discussion, I think one of the key points of the vision that we developed was the importance of bidirectional electronic communication with all the different people that are being taken care of in the patient-centered medical home, so that there needs to be, for the patient-centered medical home, needs to be speaking with the patient electronically at their home, but also with all the specialists, with the schools of healthcare is being delivered there, with the hospitals, and basically anywhere where healthcare is being delivered, there needed to be electronic bidirectional communication. So in terms of HIT, we saw that Arkansas Health could not reach the level that it needed to have without a really good system.
Absolutely, and I'm glad you brought up the focus of patient engagement and having that communication at a patient level, and that's really something that all of our organizations are taking a greater look at. And with that, Mr. Scott, would you speak to your patient health record? I understand that your organization will be using one, or will have one available.
Yeah, if you think about it for a moment, to Dr. Kahn's point, in this day and age, and I think perhaps more so than in years past, there are very few people who see simply one either one physician or one healthcare system for all of their healthcare. And so the issue, particularly about Dr. Kahn's point about the bidirectional exchange of clinical information, having that information where it's needed, when it's needed, for the purpose that it's needed, primarily informing better care decisions, is really what health information exchange is all about. And so that's true both from a provider perspective, but it's equally true from a healthcare consumer or patient perspective. And so I believe it was about 18 months ago, I read a study that said that the average person in America today, age 65 plus, sees an average of about 16 different healthcare providers and or physicians in a given 12-month period of time. Well, some people actually assume that the system automatically and that providers automatically exchange that information with each other, but you usually find out the hard way when you go from one point of care to the next point of care that no, your information did not either follow you nor did it precede you. So a part of what we're trying to do is think about the consumer for a moment who is moving between perhaps a couple of different hospital systems and maybe 3 or 4 physicians' offices, particularly if they're managing a chronic disease. And one of the things we're actually trying to do is to make it possible for that patient to actually view their health information at what we call from an HIE perspective, a health information exchange perspective. So let me just, for example, if a patient gets a lot of their care at St. Vincent's, but they also maybe got referred to a physician who only practices at Baptist, and then their follow-up care from that Baptist procedure is to another physician specialist. The way the system operates now is St. Vincent's may have a patient portal, Baptist may have a patient portal, and that specialist may have a patient portal. Well, guess what? From the patient's point of view, that means they've got to go to 3 different points of information and points of care, and then they've got to figure out how to bring that information together where it makes sense for them. So a part of what we're doing for those healthcare organizations that connect to and use the State Health Alliance for Records Exchange share is we actually have a patient portal product that will allow the aggregation of their record across multiple points of care. The obvious caveat there is that it needs to be organizations that are connected to and using share for that patient portal to work for the patient.
Absolutely. And as we understand, a key component of all this is being able to pay for it. And we understand that the EHR incentive program has helped do just that. And Medicaid, the organization that Mr. Morin is with, is a key player in the state of Arkansas with helping oversee those incentive payments, especially for the Medicaid providers. And Mr. Morin, would you speak to what all you are doing in your agency and what types of payments you all have made with regard to AIU and meaningful use?
Well, as you know, we have worked closely with AFMC from day one to launch back in 2011. The huge effort that they put forth with the eHealth Summits, large group of eligible professionals were really interested in how to get this provider incentive. And the good thing is, even if they had it already, they didn't miss the boat because they can either adopt, implement, or upgrade. So even if they had it already, they can't say, well, I already put the money in. If they upgrade to a certified electronic health record system, which is what we want, and if they qualify, then they get their $21,250 in the first year, $8,500 5 years, after that, and totaling $63,750. They can skip also. They don't have to have consecutive years. Stage 1 is adopt, implement, or upgrade. And that's the big part of it, is the first step of getting the money. And the good thing is when they actually register and attest to receive the money, they do not have to have it. They didn't have to have it. Now they do a contract. But as long as they have a signed contract, then they get paid, then they can move forward with it. And that's a big help. When you're talking about 4 or 5 physicians under one roof, that's a lot of money that could really go for the electronic health records. Right now we're moving forward with Stage 1 meaningful use. We've had a total for adopt, implement, or upgrade, which is stage 1, 1,051 eligible professionals have received payment, totaling a little over $22 million. The hospitals have received, a total of 47 hospitals have received an AIU payment, totaling a little over $17.5 million. And for stage 1 meaningful use, 354 out of 1,051 have already applied to stage 1 meaningful use. And that total is a little under $3 million. And 34 of 47, which is a good number, have hospitals have received close to $12 million. So you're looking at a total of 1,486 payments being made. The total for eligible professionals is close to 25 million, and a little over 30 million for hospitals. So close to about $55 million has been paid out. And the good news is we've only had to make one recoupment of $8,500. So I'd say that's a really good percentage.
Absolutely, I would agree to that, and it's remarkable to see the great work that your organization has done in overseeing facilitating these adopt, implement, upgrade payments and meaningful use payments, and really accelerating the adoption of EHRs, both from a provider standpoint and from a hospital standpoint. And I would also like to transition over to Mr. Fuchs, who is the Chief Operating Officer of AFMC, which also is the Regional Extension Center, and have him speak to the work the REC is doing and AFMC is doing under its many scopes to really emphasize health improvement and work with HIT.
Thank you, Nathan. It's quite remarkable that AFMC, for its longest time, has been primarily considered a quality improvement organization, stating almost over 40 years working with CMS and Medicare and Medicaid over the last 15 years, working with providers on any number of different initiatives as it relates to Medicaid policies and procedures, as it relates to Medicare quality improvement activities. And what the Regional Extension Center was able to do, once we were fortunate enough to receive the grant, was expand that provider outreach capability. And so with all the activities that are happening in Arkansas today, and when you think about it, how remarkable it is that this state is almost the center of healthcare reform activities, and all the myriad of tasks that are being tasked to providers to meet in terms of various initiatives, be it there's the payment reform initiative, be it the patient-centered medical home and CPCI, patient-centered medical home on the Medicaid side, CPCI on the Medicare side, the Million Hearts campaign, where Arkansas is literally number 1, if not number 2, in the nation relative to provider signups, over 3,000. Oklahoma is second, and I think the third one is about 900 providers, which is Florida. The fact that the work that we do with the Quality Improvement Organization and going into hospitals, physician practices, nursing homes to help them achieve the various CMS, PQRS, and QIO requirements. It's just inordinate the amount of work that is being done on an outreach basis by our staff. So to add to that, this remarkable program of the Regional Extension Center, which is to help providers determine whether they can even achieve and are ready to bring on an electronic medical record within their practices, get them through the practice workflow requirements just to get them up to speed to be able to choose an electronic healthcare record, give them criteria to work with various vendors so that they can choose one that's appropriate for their practice, then adopt, implement, and upgrade, as Ed mentioned, which is a major milestone, and then at the end of the day, attest to the meaningful use criteria, which, when you look at it, is similar to what's being required for CPCI, similar in many ways for PQRS. And how do we make it simple for the provider so that they really only have to sort of make these reports in one fashion as opposed to all these multiple silos? So just to give you a sense of where we are, our original task with the ONC, Office of National Coordinator contract, was to get 1,280 providers across the threshold for meaningful use by February of 2014. We currently have about 1,500 providers that have signed up with the REC. About 100 of those are specialists. The rest are all eligible primary care or OBGYN, and that's about 114% of the target. About 1,160, I wouldn't say about, but that's a real number, 1,160, or 91% of our target have achieved, adopt, implemented, upgraded, and go live. So they're actively using their EHRs. And 673, or 53% of our target, have attested to meaningful use. We have any number of large groups that are about to cross the finish line over the next 3 months, and it's just been a very, very exciting time and very positive, because it's not only our implementation specialists from the REC that go out and talk to providers about these issues, but our Medicaid provider outreach staff and our QIO quality specialist staff. It's all an integrated kind of process, particularly when we talk about CPCI, which is the Medicare primary PCMH program. It's really a multidisciplinary team to get the right person to the right practice at the right time for the right issue. So with that, we have now going forward to our ongoing sustainability, where we're talking about next stage meaningful use, EHR optimization, ongoing assistance relative to clinical informatics, back to those multiple requirements that are being asked of these providers, which are daunting in and of themselves. And when collectively, when you add all these other activities that are going on to the state, our real task at the end of the day is, how do we make it simple for the provider to utilize this magnificent instrument of an electronic healthcare record in an appropriate manner that benefits that practice, that helps them in terms of their patient population wellness, and at the end of the day, provides for greater patient engagement.
And I really want to highlight the amazing work that's been done by these multiple teams to see the adoption in Arkansas of electronic health records to where it is today, having over half of the target established by the federal ONC, Office of the National Coordinator entity. To see more than half of those providers already reaching meaningful use is absolutely a remarkable feat. And we also know that just achieving stage 1 meaningful use is not the end of the road. It's not the final task at hand. To Mr. Scott's point, we have to be able to share this information. We have to be able to help providers make educated and more informed clinical decisions based upon the actual patient's experience at these different facilities. And we understand that share is a key part of that. So with that, I would like to turn it over to Mr. Scott to speak about the state's HIE share.
Thank you, Nathan. You know, one of the things I would say kind of as an intro to that is that I think we all know, because we work in the field, how valuable and how important health information is and data is. But I think historically, I think we've tended to treat it much like many people treat money, in that we've kind of taken most of the value in having it, hoarding it, storing it. Some of it got analyzed, some of it got used for a wide variety of purposes, usually in the payment arena, usually around setting insurance rates, etc. I think in the current state of affairs of healthcare system reform in the United States, I think health data, health information has become a kind of a new currency in the healthcare marketplace, because partly because of the meaningful use requirements, and you know, we use that term a lot, but when you really think about it, what it says is you're not getting an incentive payment just because you bought an electronic medical record. You're going to get the incentive payment if you actually use that tool and use that information in a meaningful way, which, if you look at the ultimate definition that ONC uses, has that information actually helped inform the care process? Has it improved the healthcare delivery and or healthcare outcomes for that patient? So in our space, in terms of health information exchange, we literally mean it when we say it's not having the data that's important. The question is, are we moving it and using it in a way that it actually is has a meaningful impact on the healthcare system, and particularly both for the provider and for the patient? So we started actually in December of last year, what we would describe as fully implementing the SHARE, State Health Alliance for Records Exchange infrastructure out there. And quite frankly, we'd spent 2 years plus planning and built and trying to, design the technology. But since December of last year, we're now starting implementation in our 7th hospital system. We're approaching 500,000 discrete individual patient records in the SHARE pipe, if you will, in the pipeline. And for those 7 hospital systems, many of which, when we talk about systems, what we mean is it's not just the hospital facility, it's the facility and all of either the affiliated and or acquired clinics and practices they have. So if you kind of add up not just the 7 hospital systems, but all of the community health centers and independent freestanding clinics and everything else, we're now in excess of about 100 and somewhere around 110 different sites around the state, both urban and rural. We've made a special effort of trying to particularly reach out to the small rural hospitals and critical access hospitals, which are often a kind of a forgotten link in the healthcare network around the state. So we think we're making great progress, but quite frankly, we've really only begun this process. But we're very pleased with the response we have gotten from the healthcare community, and we're getting, I think, we're getting to the point now in terms of traction and in terms of appeal for connecting to and using SHARE. We're getting to the point now where the whole concept of recruiting that we used for the last year and a half is kind of now taken on a different meaning, because we're actually having people contact us and asking, when can we be next? When can we get in the queue to get connected to and use SHARE? So it's the technology in some ways is complicated, but I think the thing that keeps us motivated is if you go back, for those of us who can go back 25 or 30 years ago and think about before we had cell phones and before we had debit cards, and the part of the frustration, I think, for many of us, excuse me, who work in healthcare is that in healthcare technology, that is the use of technology and instruments and laser surgeries and robotic surgery and all those kinds of things, the U.S. is way ahead of other parts of the world. But when it comes to using health information technology, that is, how are we actually using these literal warehouses full of patient data and clinical information? We still act like we're in 1970s. It's still a largely paper, in spite of all the progress, Jonathan, we've all pushed and made. We've still got very large healthcare organizations out there that are a paper-based operation. I had a conversation with the health department yesterday, and a large hospital that shall remain nameless sent them a package of 2,000 individual shot records for them to key into the immunization registry. Now, folks, we're at an age where there is actually no excuse for trying to manage critical information, Dr. Kahn, as critical as immunization information is. And so, I think we're all committed to trying to push this envelope even further and faster. But we are making progress, but we've still got a long way to go.
Absolutely.
Well, and on the same line, there are all of these initiatives that have been mentioned, and without this technology working, it's going to be very difficult for these initiatives. Payment Improvement Initiative, to be able to make that work in your practice, if you're a provider, you really have got to know where the money is being spent and who's providing services, and make sure that tests are not being duplicated in another part of the health system. And if you don't have your EHR up and running and connected, to all the other places where health is being delivered,
Right.
you aren't going to be able to manage the finances.
Right.
So every part of this is connected, and
Absolutely.
without this health information exchange, it basically won't work. All these other initiatives won't work.
Absolutely, and similarly with the CPCI and PCMH
Exactly.
initiated activities, apart from the payment reform, which is a catalyst of extraordinary measure, it can't be done.
So Jonathan, let me just pick up on that, because one of the things that we are working very closely with the Medicaid program on is that for their Medicaid-driven patient-centered medical home initiative, one of the options that's available and one of the opportunities that's available is that for all of those practices that are going to participate in that, if they are connected to SHARE and they are using an electronic health record system, the quality metrics and clinical information that they're going to be asked to report out can actually be extracted from their electronic health record, assuming that product has that ability, and transferred through SHARE to Medicaid or to whomever they've been asked to report this data to. Even for practices that are still paper-based, we're actually coming up with a less automated and more manual way for those people to connect to SHARE and use as well. So we're, again, working closely with Medicaid, trying to coordinate that effort. Because in that sense, Jonathan, I think your very important point is that we're not trying to suggest that SHARE is the silver bullet. It cannot do it all. But what it can be is the glue that can kind of hold the system together. It can be the mechanism that actually helps us connect the dots. And the other point you made earlier, Dr. Kahn, is that we've, again, not just the example I gave of the multiple physicians that people access in a year, but we've now got multiple points of care. You know, not all care occurs in the four walls of the doctor's office, or certainly not in the hospital. So the school-based clinics, we now got retail outlets that are running clinics. We've got docs in the box and all kinds of entities out there. And so what we think is that SHARE, the Health Information Exchange, actually, we like to think of it actually more like a utility. It's something you should be able to plug into and move information wherever you need to move it. SHARE doesn't do anything with that information except transmit it. You know, we don't decipher it, we don't interpret it, we don't analyze it. We simply are the transmission mechanism to actually help make that connection. And so if you think about a hospital system that has multiple referrals coming in from multiple docs scattered perhaps all over the state, if you're someplace like UAMS, if they want to be able to electronically communicate with all of those referring physicians, before SHARE was developed, they literally would have had to build those connections one at a time, point to point. What we offer, again, is kind of the hub and spoke approach. So if we're getting UAMS connected to SHARE, and we're getting all of those referring physicians connected to SHARE, then UAMS actually only has to make one connection, and that's to SHARE. So that, in essence, is kind of the concept of how it works.
I don't think we can say that enough as far as meaningful using, because once you get that, once you adopt, implement, or upgrade, and you do have it in place, stage 2, 3, 4 meaningful use, that's the whole purpose of it. So we have...
And each year, Edward,
Yes,
to
sir.
your point, each year those requirements,
Yes.
Get
right,
more
they
intense.
increase. They get
Yes.
more intense. Exchange and meaningful use actually has a deeper and broader meaning each year, right?
Yes, correct. And out of a little over 1,354, we need to target the ones that haven't meaningful used yet, or hopefully they are in the process, which is where y'all would come in. And that's when AFMC and myself are going to team up and start hitting these targets as an effort to show these providers that we're working together. You know, y'all are
Absolutely.
contracted, but we work so closely with with this room that with the
Same
presence,
here.
with the presence of, we're here to help. And I
Right,
think
right.
once we start doing that and the word of mouth gets out, everyone will come on board.
And you mentioned it, and I just want to emphasize it again. Meaningful use is just, I don't want to say it's a stage, but it's a vehicle to approve not only the utilization of these systems, but to really work very closely back with the practice to improve the quality of care that they're providing on an individual and population basis. And so it's not meaningful use 2 or meaningful use or 3 or meaningful use to infinity and beyond, but it's really all these various quality measures. And what I've been trying to sort of articulate, and often I don't do that very well, but I try to articulate the whole issue of clinical informatics. It's not simply the reporting requirements of Medicare or Medicaid in terms of these PQRS and CPCI and patient-centered medical home.
The alphabet soup.
The alphabet soup of requirements. At some point, those will become rote and routinized within the systems. And it's a question of how you train the provider and their practice and the folks who have access to these systems to utilize information that they need for their own practice to improve the population wellness of their practice. It includes patient engagement by all means, but it's not simply enough to check off a box, I met PQRS or I met meaningful use 1. It goes way beyond that. It's sort of like what's the fisherman analogy? I can cook a fish for you, but if I teach you how to fish,
Something.
I don't do an Arkansas analogies very well, catfish or something like that. Anyway, that's a point that I think we cannot forget, and also, how do we make it easy for that provider?
That's
Because provider fatigue is a it's now become a cliche, but it's very, very real. And I often think of, if there's one thing that keeps me up at night, is a provider saying, I've had enough of this. Forget it. I'm not parting of any of this. I just want to practice medicine. Leave me alone. And our job collectively is how do we make it easy for that provider to meet these requirements and at the same time allow them to do what they really were trained to do, which is practice medicine.
Well, I think the first step of that, speaking as a provider, is that we need for providers to understand the big picture. What's in it for them down the road? When you're, I've done this twice, gone from we went from a paper record about 13 or 14 years ago to an electronic record. Now we're gone to another electronic record. And it's a lot of work, and it's a lot of trouble, and it's very difficult. To be able to say to a person, the reason you're doing this, the light at the end of the tunnel, is that you will be able to, when you open that patient's record in the office, you'll be able to see all their information from everywhere they've been without making 3 or 4 phone calls. You'll be able to prescribe without writing out a bunch of prescriptions and calling the pharmacy and finding out which ones they've filled and which ones they haven't. And all the other functions that are made possible by sharing the information exchange. If a person understands all of that, why they're doing all of these things, they're more likely to not say, I've had enough, I quit. But I don't know that we're there yet. I don't think most providers really, when they're struggling with the first time using an electronic health record and how to figure out how to make it work, they're not really seeing that, and eventually this is going to be so helpful for me that I'm going to stick with it.
Well, if I could, let me just take this to one more level, because I think Jonathan's point, and I think we've all talked about provider fatigue and the fact that, every new initiative comes along, has another set of requirements. And so there are a lot of conversations going on about that, about the need to at least align, if not in fact mirror and marry a lot of the data requirements, so that at the provider's doorstep, they don't find themselves logging on, logging off, 10 times to participate in 10 different payment schemes kind of thing. But I do think it is important to point out that part of the provider fatigue is actually a byproduct of the way we have also set programs up in the past. And my friends at the health department are struggling with this right now. We've got 13 different registries, all of which have mandatory reporting requirements, Dr. Kahn, for the medical community. And all of those registries are siloed programmatically, and one of the very first hospital systems we connected to share, one of the first things they said is, right now for us to be able to submit public health reports, we have 5 different log on and log off requirements or processes. isn't there some way SHARE could actually help simplify that? Well, they were spot on, because we've actually been working now for a year with the health department trying to build a connection, build an interface between SHARE and the health department information systems over there in a way that it really can eventually be reduced to kind of a one-click environment. And once you're there, then you can navigate to whichever. We've got 3 cancer registry, we have HIV, immunization, TB registry, on and on and on, all of which is good. I mean, that you talk about needing critical information for public health and syndromic surveillance. But again, we have, I think, very unintentionally and perhaps even unconsciously made it frankly difficult for the provider community to actually comply with the very laws we've passed and said, effective this date, you must report this. So again, in a utility sense, we're not doing it for the health department, but what we're trying to do is help make that process work easier, both for the provider and for the health department as well. And we actually yesterday had kind of a red letter day. We have been struggling with some technology issues around the immunization registry. Like a lot of software and hardware, there's always requirements and systems and versions, and things don't always easily communicate, and it's not always a plug-and-play environment. But we finally yesterday kind of solved the riddle that we were having with the immunization registry. So literally starting today, we are now going to be able to offer to hospitals and practices the ability to, if you're connected to SHARE, there will be a thing called the Immunization Gateway, which will hugely simplify the whole immunization registry reporting process. So the health department's very excited about it. We're very excited, and frankly can't wait to kind of get the word out to the physician and hospital community. So that hospital that sent 2,000 paper shot records and said to the health department, would you key this in with our number? We hope we can put an end to that kind of behavior.
And that's a key part and focus of the Regional Extension Center in helping providers, even with the immunization component, syndromic surveillance component, with meaningful use. And SHARE certainly will help facilitate that much easier than before. And Jonathan, would you speak to the REC's ability to provide some hands-on technical assistance? Because we all recognize that with these different initiatives, these different requirements that are pushed out, you can do some things virtually, and over webinars is okay. But there's other components of this training and this hands-on assistance that is really needed in the clinic with face-to-face assistance. And that was one of the key charges of the Arkansas Regional Extension Center. So Jonathan, would you speak to that and then the way that the REC handles that?
Well, we have a staff of about 8 or 9. 9, is it? How many do we have?
Now we're up to 10.
We're up to 10. We grow leaps and bounds. 10 implementation specialists who have skill sets in terms of either because they are experts on a particular EHR system, or they have practice management experience in terms of workflows and having been practice managers using electronic healthcare records. And at least in Arkansas, it's become clear to us in our many years of experience of working with providers is you really need to have that relationship with that practice and the relationship with the provider, because you can walk in and you can say things and you have credibility and resources behind you that they have experienced in the past and have proven to be valued. That's really, we come in with a large list of checklists and toolkits and listings, and we sit with that practice from the very beginning, as I said early on, in helping them assess their workflows, helping them in terms of their security risk analysis, because privacy and security is such a big function in terms of the meaningful use requirements, and the use of these systems requires that they be sensitive to the patient privacy and security. And we walk them through every step of the process. Some practices, I'll do it myself. Thank you very much for the checklist, and we're out the door. And some practices say, we don't need you. I say, well, good luck, and call us when you get audited. And some practices say, we can do it, but we really need your help. And we had an experience just the other day with a large pediatric practice up in Jonesboro, Dr. Matthews' practice, and they were stuck. They were at an impasse. They had some problems with their system, and they had an upgrade, and it wasn't working. And one of our implementation specialists was there that day, sat down with them, calmed them all down, and said, this is how you can proceed to correct this issue. And at the end of the hour or two that she was in that meeting, they were all, smiles and happy, and things were sort of working again. So it's really that one-on-one relationship, that one-on-one working with the practice, which we think has a lot of value. Obviously, as people get more sophisticated, it may need more just of a touchstone. We're getting a lot of people who have already met meaningful use, have already attested, and they say, well, you're not going to leave us, are you? What are we going to do next year? And so we have created opportunities for our staff to continue working with those practices. But it's really that relationship and the credibility of the outreach staff across the board of AFMC, but as well as the Regional Extension Center, that I think has really been what's made us as successful as we are. And Ray Scott, in terms of his organization, have folks that he's contracted with from a technological side, in terms of the onboarding into Share, that are experiencing similar kinds of feedback. It's very important that you be in that practice. You cannot always do it on a virtual basis.
Well, and I think, Jonathan, it's important to just, for me to, I think, underscore this whole notion of collaboration, because, the one thing that was pretty obvious early in our development 4 years ago was that, going out and making cold calls to physicians' offices and hospital systems was a non-starter and somewhere we didn't want to go. So obviously the information that we were actually able to work with both the REC and Medicaid on, us actually communicating and exchanging what knowledge we had about what practices had actually adopted and were using record systems. And so I think from day one, the collaboration and the partnership that we all have developed working with ACI, given the knowledge that they had, quite frankly, I think that's a part of why Arkansas has made the progress we have, to your point, Jonathan, in many ways far beyond where other states who started before we did have not achieved. So I think, the ability to get the right people in the room, as we're doing today, and actually exchange meaningful information that actually helps drive decisions and helps us put in place a plan that is a very strategic approach, and therefore we're not running around wasting a lot of resources, looking for prospects that are actually right there. And that still doesn't mean it's an easy sell, because again, for Dr. Kahn, the points you made about, again, this is not a plug-and-play environment. It's not like just, going to Walmart and buying a new piece of software and taking it home and putting it on the computer. It's the workflow analysis, Jonathan, that your folks do. And again, it's the most critical part of the whole process is, are you going to use it? And if we can't help it work into your workflow in a user-friendly, non-disruptive way, then you're not going to use it, or people are going to continue to resist using it. So I think the partnerships that we've created, Nathan, have just been invaluable, and I think they're going to continue to pay dividends for years to come.
In order for these initiatives to be successful, absolutely.
Absolutely. The final question that I would like to pose to our stakeholders today is, are there any particular dates that providers should be focused on with respect to each of your organizations? Any upcoming deadlines or dates that we should make aware of?
Well, the first one that's upcoming is for those providers that are on the Medicare track, because it's different than the Medicaid track, even though there's some commonality to it. They have different payment levels and they have different requirements. October 3rd is the last day for providers to begin their 90-day meaningful use qualifying period for this year. So they must register with CMS, use their eligible EHR for 90 days to receive meaningful use subsidies, and And they risk, a lot of people risk if they don't do that, of facing some Medicare rather, penalties if they don't achieve that. So October 3rd is really critical for a great number of providers who are on the Medicare track. On Medicaid, there's still a window of 3 more years, 2 or 3 more years,
Yes.
without any penalty that is projected at this time.
As of now, I know of no penalties for Medicaid.
Okay.
But you are correct. 2016 is the last year, which gives them plenty of time. And that's 2016 is the last year that they can get the full payments. And that's the last year they can register.
And you made a very good point, full payment. If a provider doesn't meet that October 3rd deadline and they attest the following year, the ultimate total amount of dollars that they could receive will be lessened. And so it won't be the $42,000 or $44,000, it might be something less. So
That for Medicare.
Medicare,
Right.
Medicare, not for Medicaid.
And the good thing that the rules have changed. When we first started out, as we all know, you had to have 90 days previous calendar year to show your 30% patient volume. Now it's just any 90 days prior to. So no one has to wait January, February, March. They can just start right away.
That's on Medicaid, yes.
Yes, for Medicaid. So that change has actually helped providers a lot. And knowing that they do have 2016, it's great, but we really want to push forward for them to move now and not wait till then, because if they're going to miss the boat and everyone else is going to be exchanging with share, they're going to be in a bad situation. I mean, they're just going to be left behind.
And for those primary care physicians who haven't signed with the regional, this is a marketing pitch, I guess now, who haven't signed with the regional, we're still accepting folks. I mean, we're not saying, no, we met our requirement, don't call us. There's still opportunity for us. Our grant officially ends on the 14th, February 14th, but there's lots of discussion for extending that in terms of our services, and we should have confirmation of that in the next 2 or 3 weeks from the Office of the National Coordinator. That's not to say you shouldn't call us. That's not to say you should wait. We are there to help as much as we possibly can.
Absolutely. And as 2014 quickly approaches us, we're all looking at stage 2 meaningful use, I know, both on the hospital and the provider side, Medicaid on the policy side, and making sure that providers are ready, and of course coordinating with SHARE as the communication between providers and patients through a functionality such as SHARE is going to be increasingly important.
And I should mention, because I didn't before and it was my error, we also work with 18 critical access hospitals. The other 6 or 7 are affiliated with larger systems, so they're absorbed into that matrix. But we believe that all 18 will have achieved stage 1 meaningful use by the end of this year. Most of them have already done so. I think there are only 2 or 3 that are still sitting out, and that's just a remarkable achievement, given the resource, how stretched they are in terms of personnel, resources, and dollars.
It's truly a remarkable accomplishment. And as final comments, what I would like to do is circle around the table and start with Mr. Scott and just speak to maybe some of the words of wisdom you might have with respect to really these different initiatives and SHARE and what all you provide and what providers in Arkansas can look forward to.
Gosh, what's the meaning of HIT? So, well, I think to state the obvious, we are in a period of what has been fondly referred to as mega change in the healthcare marketplace and in the healthcare delivery system. And so I think all the points that have already been made by the group here around trying to at least be sensitive to and be thoughtful and strategic about the fact that all of these various initiatives come to roost at the provider's doorstep. And so how we all align and coordinate and collaborate our efforts can, in fact, I think, make a huge difference, not only for the provider, but for the results that we're all hoping to see. Again, whether that's more closely aligning the data reporting requirements, whether it's making it a one-button, one-click solution as opposed to multiple log-ons and log-offs. There's a lot of different things I think we collectively can do to make these initiatives more user-friendly and more effective, because I think one actually goes with the other. And, while technology can be a major part of that, it's not all about the technology. It's about managing the relationships. It's about how do you bring that technology into a practice setting or into a healthcare delivery network in a way that is not so disruptive to the providers and their staff, and that then has a ripple effect in terms of patient care. So it's the thing I try to remind my team of, almost daily is if this were so easy, don't you think this would have been done 30 years ago when a lot of other technology and innovation was launched and done very successfully? So it's a very complicated thing, but I do think Arkansas is in a incredibly enviable position, I guess, if you like change and you think the system needs to be changed, because I think we're doing things in this state that are very forward-reaching and forward-looking, and in some respects we're actually pioneering. And we all, I think, have a critical part to play in that whole transformation process. And so I think a part of the advantage we have, again, is that ability to get the right people in the room and work through some of these issues in a way that we actually can come up with some good solutions.
Absolutely. And Ed, from Medicaid standpoint, do you have any recommendations for the community as well?
We just need to, what we're doing is obviously going to work with y'all strongly to get the people that aren't on board, and remind them that it's such a good thing. It's so good for the providers. It's so good for the patients to have this information and be able to access it. Once they start realizing that, they just need to keep a positive attitude. No one really likes change, and to go from a fax machine to an email, it's funny how when they're like, well, how secure is this? How secure is a fax? When you look at it, anyone can walk by and pick it up, and you're worried about electronic health records being exchanged. So what we really want to do is remind them that we're all share, like that, right? The same goal. And that is to help all the provider community.
Absolutely. And Dr. Kahn?
Well, just to echo on one of the things Mr. Scott was saying, he said we need to do this in a way that's not disruptive, but it's a little bit more than that. Those of us who went into medicine did it because we visualized ourselves going to work every day and having a nice time in a pleasant atmosphere helping people. And over the years, it's gotten less and less like that. You go to work and you call it provider fatigue, burnout, whatever you want to call it. You're spending a majority of your time doing things that you weren't really wanting to do or planning to do because of the way we awkwardly dealt with our system needs. Then if you look at what's possible with the changes that are here, that are happening now, it's almost a matter of faith. And if you can once again visualize yourself going in the morning and practicing in a place that's fun to be at and helping people, you might be able to better cooperate with and accept these changes that are inevitably going to occur, and that will make your life a lot better and will make your patient care a lot better. So it's going to be a rough few years. There's no way around that. But if you just keep in mind that vision about what it's going to be like in a few years once these systems are up and running, I think you won't feel bad about the slowdown that you have initially.
Absolutely. And to sum it up, Jonathan, with AFMC.
Well, we're in a remarkable era of change, an opportunity. I think we're going to see the emergence of patient engagement being very, very critical to the success of the population wellness that practices will have to work with. The whole issue of clinical information, how you use it to enhance that population wellness, to enhance that patient engagement, and to demonstrate the quality of care that's being provided is really going to be critical. I've been talking about quality assurance for 30 some odd years in a lot of different venues. And this is really the first time that I really believe the information is going to be there to helpfully demonstrate that a practice is providing quality of care. And it's not just hearsay, but it's actual fact. And it's, as Ray said, it's a great time to be in policy. It's a difficult time to be a provider. But on the other hand, it's really necessary, and it's about time that we got to that point. So I'm very excited for the future. And as far as AFMC is concerned, we are dedicated, as we have been for 30 some odd years, in terms of being that face to the provider community of trust and knowledge and practicality.
And with that, I want to thank all the stakeholders for their dedication to all these initiatives and to working together to really improve healthcare for Arkansans, which is the end goal for us all, really to focus on that improvement. So I want to thank everyone, and I also want to thank the viewers for taking the time to watch this video today. If you have any additional questions, feel free to reach out to us at HITArkansas@afmc.org or by clicking on the link below. Thank you for your time.